So, yeah, great that you had to read it and not me, actually. So thank you very much for inviting me, and I'm I would like to start with a brief disclaimer. This is not a modeling exercise, as you can see. It's actually a study protocol, and instead of me telling you what we found, I'm actually really interested in hearing from you how you think we can find something interesting by ameliorating this protocol. So basically, highly mobile populations, such as long-distance truck drivers, are at high risk of HIV vulnerability and transmission. This is mainly due to the reported higher risk behaviors and the lack of access to HIV prevention, treatment, and care. North Star Alliance is a public and private partnership that manages a network of roadside wellness centers that look a little bit like the two pictures in the bottom there, and along major transport corridors throughout Africa. These roadside wellness centers are semi-mobile converted shipping containers where they actually provide a comprehensive service package, not only looking at prevention service for HIV, such as PCT, STI syndromic treatment, and behavioral change counseling, but also other diseases such as hypertension and diabetes screening. And importantly, they actually have an electronic health passport system that are linking all the different wellness centers. And this allows the nurse, when she's seeing a patient, to actually recall whether the patient has been seen in another wellness center. Funded by the Dutch government, there is a service expansion that will start this month, and is to start providing treatment for HIV. Now, this treatment provision, as per guidelines, is based on the treatment program of Hillbrow that is managed by Wits University, and the same team will actually support the provision of treatment in North Star Alliance. What we're aiming to do is actually start with this north-south corridor that goes from Durban through Johannesburg, Bay Bridge, across Zimbabwe, into Zambia, through Chirundu, and then all the way to DRC, and it continues. We're actually aiming to start with 4 sites in Durban, Bay Bridge, and 2 in Chirundu, and where we will have nurse-led HIV services of prevention, VCT, staging services, and treatment initiation and monitoring. There will be outreach counselors that actually support the nurse in these sites. Then on one side, we will have a direct IRT referral if there are any patients that come up to that arrive that present late for treatment or for the follow-up of any adverse events. And it's in the context of this service expansion that we propose to pilot treatment as prevention for long-distance truck drivers and their assistants. So, considering the potential benefits of prioritizing treatment as prevention to long-distance truck drivers and the challenges in engagement and retention in care, we actually frame our research questions in terms of practical issues for delivery. First is early start of IRV therapy as part of a multi-component intervention, a feasible service model in this setting. 2, how are the costs distributed, and how can we maximize the resources available to North Star? Should this model be considered for implementation across the network? And 3rd, is this a cost-effective addition to the treatment provision service that we are also going to provide in this corridor? So looking at feasibility, as I just mentioned, we don't think that treatment as prevention is something that we can start without doing other interventions at the same time. So we are adding outreach for HIV testing, behavioral counseling, the nurse-led early initiation of RT, but also adherence promotion in using text messages and U-boxes. We aim to follow up on an observational cover of 200 truck drivers for up to 2 years. And the data that we will be collecting is in terms of case detection, early IRT uptake, but also retention in the program, self-reported adherence to treatment, but also through the U-boxes, risk behaviors, and HIV care indicators in terms of CD4 counts and viral load. Looking at the cost, we will calculate the cost from a provider's perspective using an ingredient costing approach. Data collection will be at demonstration sites for treatment as per guidelines and treatment as prevention. Current prevention services costing is ongoing. Data collection will be through observations of practice, review of North Star Alliance and their partners in implementation, financial reporting, and staff interviews. Our outcome will be cost per unit of output, being cost per patient on IRT or cost per patient on early IRT. And the analysis will include the description of the distribution of costs, both within and between sites, and also the identification of ways to improve the delivery system in terms of cost. Now, the cost effectiveness model is a model-based evaluation. We are going to use our pilot data on cost, uptake, retention, adherence, and treatment outcomes, and inform a cohort-based decision analytic model. This will actually allow us to look at the short-term benefits, the direct effects of our intervention, as well as how we can maximize, how we can estimate the changes in the budget that changes in our service will have. And then this model will be expanded to actually include transmission effects and look at long-term population level benefits. But for this, we need extra data that we have access to, and that includes sexual behavior, not only of our clients, but actually looking at other truck drivers that are and sex workers and their partner, mobility, also HIV prevalence by site and by group, coverage of our services, and relative population sizes. I would like to briefly mention that we did budget for 2 cross-sectional surveys looking at knowledge and attitudes, but now we are rethinking this model into looking at qualitative research of why, actually to understand the motivations of people that accept treatment as prevention and those that actually we can retain in care. So this demonstration project will provide insights into the operational feasibility and acceptability of an early IRV treatment service for a mobile population. We hope we will also inform North Star on cost effectiveness and affordability of this service expansion, and importantly on how delivery costs could be reduced if they want to consider how to expand this intervention throughout their network. Thank you, and I would like to thank all the people that has helped me put together this protocol. Thank you.